Thank you very much for the introduction and the kind invitation to talk about how to reduce bleeding complications and costs with the CytoSorb system for removal of Ticagrelor and Rivaroxaban in emergency situations in the field of cardiac surgery. And for our group, the onset on this research on this topic was a retrospective analysis on bleeding complications after use of novel oral anticoagulants in patients undergoing cardiac surgery that we published in 2018, from which we concluded that despite official recommendations, patients should, whenever possible, not be considered for elective cardiac operations within 10 days of terminating NOAC treatment, and that a lengthy NOAC withdrawal period is essential for safe open heart surgery, particularly in patients with reduced renal function. During that research, we discussed how helpful it would be to have a method to extract drugs that cause bleeding from the human blood during open heart surgery, something like a filter. And I want to show you that with a CytoSorb system we have such a method, even if it's not a filter. Today we're talking about two different drugs, well known they are, and unfortunately there's not enough time to go into the details of pharmacokinetics, but I think we all know that Rivaroxaban is a direct-acting novel oral anticoagulant, a factor Xa inhibitor, frequently given in patients with atrial fibrillation, for example, to prevent from thromboembolic events. It has a high degree of protein binding, and there is an antidote which can be given in bleeding situations, the andexanet alpha. Anyway, it may lead to a non-response of heparin, and this should be definitely kept in mind when it is given. Then we have the Ticagrelor, which is a P2Y12 receptor antagonist, given in myocardial infarctions, at latest at time of PCI. It has a direct acting, it does not need any prodrug, it's reversibly bound to the platelets, and it also has a high degree of protein binding, which is, as you will see, something very useful. It's not for long, and has been said in the presentation before me, that patients who are Ticagrelor-loaded have a high incidence of bleeding complications. It's something about 40 or 50% maybe at the first day, and it's still between 25 and 30% at day 2 or 3. So it's a concept to wait a couple of days, maybe until day 4, when it's non-emergent situation. But what shall we do when it's true emergency? We have to do something. And here, this experimental research has been published. That was in spring 2017, that showed that the CytoSorb adsorber is able to remove Ticagrelor from the human blood almost fully by using its albumin binding. Now, what's the configuration of the CytoSorb adsorber? Again, it's not filtration, it's adsorption, and it works completely different. When you look here, you see that in the adsorber, medium-sized and smaller molecules are removed, while the big molecules are not removed. Initially, this concept was created for the removal of cytokines and other medium-sized molecules in septical situations, but it works for bilirubin and toxins and so on. And there's another main difference to filtration. It's the overall surface, which is really so high. Now, in the field of extracorporeal circulations, it can be used in different fashions. And you see how we use it for cardiopulmonary bypass. As you see it here, with a roller pump controlling or guaranteeing continuous flow that should be approximately 500 milliliter per minute. And we're doing this since June 2017, so very short time after that experimental research has been published. We have read that paper and were confronted with a patient with a type A aortic dissection who was loaded with Ticagrelor because of prior PCI. And we took the adsorber, and the outcome in that patient was so convincing, so good, that from that day on, this was our standard procedure in Ticagrelor and also in Rivaroxaban loaded patients. And here you see a table from our first paper that we published in 2019. There was a mixed group of patients. Some have had Ticagrelor, others were Rivaroxaban loaded, and you see here on the right side a control group of 16 patients done the year before we started with the adsorption. But even it was a heterogeneous group, they all had something in common. All had an underlying coronary artery disease and all were true emergency cases. Here you see the graphical abstract we were asked to do for the online version of that paper. Show you all the results at one look. You see here on the right side the adsorber patients that we were with adsorption able to improve almost everything. The drainage volume indicating less bleeding was lower, the operation time was shorter, less transfusions, no retorocotomy, and a shorter ICU and hospital stay. And when you look at that figure, you see the 24 hours drainage volume of these patients here in green with adsorption and in blue without. And you see that for Ticagrelor and Rivaroxaban, it's almost the identical figure, so less bleeding in both drugs. The next step for us was to update our data until June 2019 and to focus more on isolated CABG patients loaded with Ticagrelor. And in these 66 patients, we found out that we reduced the total operation time for 80 minutes, which is quite a lot. I have to add that our standard concept is to use both thoracic arteries for complete arterial revascularization in almost all of our patients in a T-graft technique, and even in these emergency cases, we used it in 65% of cases. We saw less transfusions in the adsorber patients. That was not significant in the red blood cell transfusions, but it was highly significant in the platelet transfusions. And again, we saw a less bleeding, lower drainage volume in these patients here on the right with adsorption, and a retorocotomy rate of 1.8% in such patients is really very low. We became interested in economical effects and gave that data of that 66 patients back to our statistician to make a cost calculation. He calculated everything, the price of a retorocotomy and blood units and ICU stay, and performed a bootstrapping analysis, which is a statistical method of resampling. And he found out that with adsorption in these isolated CABG patients with Ticagrelor, we were able to reduce the costs for more than 3,000 euro. And the operation duration time here and the ICU stay here had the highest impact on the level of cost savings. The last thing we did was an update of our analysis was also a subgroup analysis of adsorption in patients with acute type A aortic dissection, some loaded with Ticagrelor, others with Rivaroxaban. And again, we could show that we needed less platelet transfusions in those adsorber patients. And again, we had less bleeding indicated by a lower drainage volume, as you see it here in those patients. So in conclusion, we saw both medical and economic benefits of using adsorption in Ticagrelor and Rivaroxaban loaded patients with a reduced operation time, cost reduction by shorter hospital and ICU stay, and a generally improved patient blood management. So we think that this is really a fine method that combines a reduction of bleeding complications and costs with an improved surgical outcome. And this is CE marked for this indication. Of course, there are some limitations. We present non-randomized observational study data of a single center, so definitely prospect investigations are needed, and this is exactly what we are going to do. We initiated a prospective multicenter trial with the kind help of these excellent centers. We will perform the CytoSorb Ticagrelor hemadsorption study, or short citation. The first patient is waiting to be included. Beside clinical data, we will do a direct measurement of Ticagrelor and its metabolites and a determination of platelet function with a multiplate analyzer, ADP test, and so on. So hopefully in a short time we will be able to give you more interesting data on this interesting topic. For now, for today, the adsorber method has become our standard procedure in patients loaded with Ticagrelor or Rivaroxaban. I can only recommend to make your own experience. I think you will like this method. Thank you very much.